Just as a prequel to this Syringe Driver video, I am a registered nurse. I'm working as the palliative care educator at Clare Holland House. If you are watching this, you need to make sure that you're actually also looking at any documentation that's available at your facility or your hospital. There may be a policy or procedure that's part of your organisation, and you do need to check that. You also need to find out if you need to do a competency with one of the other staff members, and that would complete your education around using the Syringe Driver. Good afternoon. Today's video, we're going to be looking at the Nicky T34. Some of you will have seen my earlier video where we actually use the prime function that's built into this device. For some of you working in aged care or in a hospital or even in the community, finding that prime function is quite challenging. So I'm going to teach you a little shortcut today. It's a shortcut that's acceptable and is low risk. Alrighty, well, just like I said in my first video, the first place to start is our patient. So we need to be making sure we're discussing with the patient sighting, whether that's upper arm, along here, on the back of the scapula, the abdomen or the thigh. We also need to be discussing with the family and patient the purpose of the Syringe Driver. We do have a legal order, of course, and hopefully the medical officer will have had a discussion with the family about setting up the driver. As you can see, this is legal. We've got date, we've got a birthday, a name. The combination of drugs I've got up there could actually be for symptom management, not for end-of-life care. And I think it's really important families don't associate setting up a Syringe Driver with end-of-life care, because that may not be what it is. So we've had a chat to Mrs. Blue Square. She knows why she's receiving a Syringe Driver. We've fielded any concerns from the family, and now we can head off and start to put together the equipment. I've divided this procedure into a couple of steps, and I'm going to focus now on putting the line together. It may be that your patient already has a butterfly in situ and you're simply going to connect the extension tubing to that butterfly. But I'm actually going to imagine I'm starting from the beginning. Most of you will be familiar with the safety intima. I'm not going to focus on aseptic no-touch technique, but you will notice that I did wash my hands. I'm wearing gloves and I am minimising contact with the equipment. So I'm using the packaging to my favour. The first thing we're going to do is we're actually going to remove the clamp. This can be a source of device-related pressure injury. I'm also going to check my extension tubing, and you can see here this one has a volume of 1 mil. I wouldn't want to be using tubing with any more volume than that. As I open it up, you can see that we've got what's called Lurlock ends. I've got a male and female end. What I'm going to do, I'm going to hook that up to my butterfly. Now some of you will just hook that straight into the butterfly, and that's fine. Some of you might have access to these, and there is an advantage to using these, which if I get a chance I'll tell you about at the end. So you might see either the line going straight into the butterfly, or you might see that safety bung going in there, and then the line, hopefully, will go in there. Okay, so now we've got a line all ready to go. Don't be fooled by this bit. Just pop it to one side and you'll see how that will work in a minute. Now the next thing we need to do is we need to focus on drawing up our drugs. Obviously I don't have real drugs today, so we're going to do some pretending. We're going to need a label for the syringe. That's the national standard for subcutaneous medication. We're going to need a 20 ml syringe. This one's a BD Plastipack. We're going to need some diluent. In most instances, it's going to be normal saline that we're going to be using. Some of you might have access to a document like this. This is from, well, you can see from the title, from the Eastern Metropolitan Regional Palliative Care Consortium. It's 2016. It's quite an up-to-date listing of drugs and how they can be combined. Today we're using haloperidol, metoclopramide and morphine. You can see it's getting the big tick, and in fact we could dilute it with either normal saline or water. I'm going to choose saline today. I prefer to draw up the drugs separately. Today we've got one drug that's actually quite a big volume. In order to get 30 milligrams, we're actually going to be drawing up 6 mils. So I'm going to use a 10 ml syringe to draw that up. My pretend morphine is only 1 mil. And I think that's actually real haloperidol, again, is going to be a small quantity. So I'm going to draw them up separately. I'm going to start off with the maximum. Some of you might think this is a waste of resources and you might prefer to draw it all up in one go, but I actually find for the sake of accuracy, and obviously you're checking this with either an RN or an EEN, you're checking the drug, you're checking the expiry date. You can see I'm also using a drawing up needle that has a filter in it. So you all know how to do this. In relation to picking syringe driver sites, I guess it's just worth bearing in mind that the abdominal site probably isn't suitable if patients have got ascites. The thighs are not going to be suitable if the patient's got edema or they're, likely to be moving around a heap. And the back of the scapula is probably quite good for people who are going to be trying to pull it out. So, you can see. Now, Maxilon's a classic, you'll all know this. We've got way more drug than we need. But actually, to get the 30 milligrams, we would have 6 mils. I'm not going to teach you all how to do drug calculations, that's for another video. But by drawing up the drugs separately, I can be really confident I've got the right amount. I'm checking each ampule with my counterpart. And if you do get interrupted, then you can at least keep track of where you're up to. So there's my 1 mil of pretend morphine. I actually don't throw out the ampules till I'm done, again, so that if you do get distracted, you've got an opportunity to double check your work. Also, if you need to do a drug calculation, and I'm not going to do it today, but I actually suggest you use a calculator every single time. Even if you know the answer, I think it's a really good checking thing. So I'm only actually going to need a tiny amount of this, 0.2 of a mil. And so this is the advantage of drawing it up separately, is I can be absolutely 100% got the right amount of drug in each one. That's lovely. Obviously my label will reflect that. And I just put a pen. There we go. So we've got Mrs. Blue Square. We've got her date of birth. Fortunately it's my birthday, so I've remembered that. And it's actually part of the national standard that when you are combining drugs, that you do actually label the, you all know how to do that, I'm sure. Some of you may work in hospitals. We're going to make it up to 18 mils. The rate, and you'll see I'm right, but you can check at the end. Today is indeed I think I've invented the day. And of course I would have a counterpart signing that syringe. So I've got my label, I've got the 20 ml syringe. Now I'm going to do a bit of, so we're going to pull that right back and we're going to add. So the first thing, and then great opportunity, check again, check again. So we've got our 30 milligrams of metoclopramide. We've got our 1 ml of morphine and that 1 milligram of haloperidol, all gone into the sharp spoon now. So for those of you paying attention, we should actually have 7.2 mils in the syringe. Yep, we do. Okay, so now we're going to add some saline and we're going to make it up to 18 mils. Probably wondering why it's such a weird number, but it's actually about what will fit into the device. Right up there. If you're not priming a new line and you're just making it up for 24 hours as an existing line that you don't need to change, you might want to just make it up to 17 mils. Certainly with this brand syringe, it is a bit of a squeeze to get 18 mils in. So we don't quite have enough, so we're going to need another. And in fact, that's right. If I've got 7.2 and there's 10 in a normal saline ampule, those of you that are good at maths will know that I'll have needed to crack that second one. Alrighty, so there we go. We've got 18 mils. It's made up with normal saline. We've got our Maxilon, pretend morphine, and some haloperidol. You'll notice that I'm going to label the syringe. I'm actually going to dry that so it sticks properly. I'm actually going to label it so that you can still see the increments on the syringe and you can read the label accurately. So we've got our medication. Beautiful. And if you remember, we made up our line earlier. So now, before we've even gone to the syringe driver, we can take our 18 mils, pop it on the end of our line, and in this case, a brand new butterfly, and we can actually prime that line. Now with the blue bung in there, we're going to need, it's going to be 1 and a bit. There we go, you can see that that line's primed. It's actually just over 1 mil. So now we've got labelled syringe, primed line. We've only lost an 1/18th of the milligram dose in that first syringe driver order, which really minimises the impact of manually priming the line. Now we can get our syringe driver. Syringe drivers, as you know, run on a 9-volt battery, and you do need to make sure you've got a supply of batteries because you'll be changing those every 2 to 3 days. I'm going to start by turning that arm up and away from the screen. If it's sticking up, the buttons won't work, so we're going to push it right down and we're going to turn it on. And you can see, I don't know what was in the syringe last time. It was obviously quite a big syringe. You can see that it's saying load syringe. Can you all read that successfully? Yes, okay. And for those of you that remember, the syringe goes in, the head of the syringe goes in those pins, the flange of the syringe goes in there, and if you remember, there's a little silver spring in there, if you can see it, and that needs to be that's the way of telling the syringe driver that the syringe is in correctly. So I'm just going to do that. I find it much easier to use my right hand to manipulate the buttons. You can actually see I need to adjust it very slightly, and my syringe is going to go in. Sometimes actually getting it in, it's easy to put it on the table. So we've got it in nice and firmly. We can put the arm up and over. You can see we've got the head of the syringe in those pins, we've got the flange there, and the syringe driver is telling us I've got a 20 ml plastic pack, which is indeed true. Now, for those of you who remember the prime function, who remember I've said don't press yes, you can now press yes. So we can confirm we've got 17.1 mils, so we lost just under a mil in priming the line. It's running over 24 hours, and the rate, it's made a little bit of a liar on me, 0.71 mils per hour. Usually it'll be around the 0.71, 0.75 mils per hour. Pressing yes to confirm. Now we could start the infusion, but there's just one thing missing, and that is the patient. So we can go back to our patient. Most patients can tolerate opsite or tegaderm, and obviously optimally we want a transparent dressing. If they're allergic to that, you might have to consider something opaque like Mefix, which is less than ideal. Now I'm just going to make a note on the little sticky tab of what drugs. I'm not going to put the dose, I'm just going to put what drugs we have in here, just so that we know what's going down the line. So I've got my alcohol wipe, got my opsite. My patient knows why I'm doing this and we've already picked a site. Now it's just a matter of coming along with our primed butterfly and the correct line. If you look carefully, you can see one side of this butterfly has little bumps and one side doesn't. The side that has the bumps is the side that we hold. And I think wings up because it's a butterfly. Obviously on a real person, I would gently push the skin together and lift up the fat from the muscle, so that I'm going to go into the fat layer, giving it a nice wipe. You don't want the site to become infected. If you're thinking about the angle of insertion, look at your patient. So a very thin patient, you might actually have to go at a slight angle because we are aiming for that fat layer. So we insert. I like to secure it before I pull out the cannula, like so. Now I can hold it down and I can pull this out, and you can see now the role of this is to pull out what is now the needle, and that will go in the sharp skin. Just taking a little long, just going to guess. And now with that secured nicely, we can now come back, do a little bit of housekeeping. It's actually easier with your gloves off. A little bit, and also this is blue square, isn't as sticky as a real person. So we've got that. There we go, and then we're going to pop this. Now I personally think if you pop it here, if the patient accidentally pulls on the driver, it's going to pull here, not at the insertion site. So it's going to optimise the life of our insertion site. Our little machine was sitting there very quietly, waiting for us. It beeped because we took too long, but it's consistently asking us, do we want to start the infusion? Well, yes, we do. So there you go. You can see that we've got it running at 0.71. You can see it says pump delivering. If we're really, really lucky, that little LED will flash green in a jiffy. Well, maybe not. Okay. We're nearly finished. Everything else that we need to do now is basically housekeeping. So this little blue button here is really useful. One press will give us an infusion summary. So it's actually telling us that we haven't infused any because we've primed the line manually, and we've got 17 mils left. A second press will give us a battery level. Now I personally think changing the battery when it's 30% or less is wise. And then the third press is a press and hold. This essentially locks the keypad and it stops anyone from interfering with the syringe driver. The second part of our security is using a locked box. And for most of you, the keys for the case should be on your drug keys. Big window, screen, pop it in there. Now, the bigger syringe is probably just takes a little bit of gentle manoeuvring to get the case to close properly. And also make sure that you don't trap the line in the case. So you can see I've just had to pop that in there. My key, if I can get it in the hole. And it's hopefully the right key. You'll all be laughing at me up there. Where's the key fitting? Aha! Okay, you can see the key. Now you can see how the key works. It turns that little barrel and it locks that. So now the case is secure. The keypad's locked, no one can press any buttons. And if you're lucky enough as we are, you've probably got some nice case that you can slide it into, and that can be then hung on the patient's shoulder, monkey bar, or tucked under their pillow. And that, my friends, is setting up a syringe driver using an 18mm load. Thanks.